Chapter 2, Communication, Computer Essentials, and Documentation. This chapter is going to go over basic communication in the medical field, as well as essential computer skills and documentation we do in the lab. There's a couple key communication strategies. We have verbal skills, nonverbal skills, active listening, electronic devices, and handwritten language. Being aware that during this communication, especially for verbal skills, the message from the sender to the receiver could be interrupted by age and gender, language, noise, sensory impairments, use of medical jargon. So we'll be covering that as well in this PowerPoint. Filters that can interfere with communication include medical terminology or jargon, language differences, so if you speak a different language and have to translate it into the language you understand, sensory ability, so speech or hearing impairments, and the pace, tone, and volume of one's voice might relate urgency, might be very loud. Those that are hard of hearing might speak louder, thinking that those, because they can't hear themselves speak. So keeping that in mind. So filters that can interfere with communication, again, urgency of the situation, cultural meaning, environmental noise if the TV's on, or gender or age. How we perceive certain language is seen differently by the age groups. So for an example, how you talk with your friends is going to be very different than how you would talk with your grandparents, let's say. Verbal communication is to show empathy for waking patients up, disturbing them, or interrupting meals. Show respect for their privacy, their condition, and their medical and their family members. Build trust, maintain confidentiality, explain procedures truthfully, and establish rapport. This is common courtesy, show interest. Us as phlebotomists, we do wake patients up at 4 or 5 o'clock in the morning. So we do need to show empathy and have respect. If they do have family members and their doctors or clergy, we will then permitting leave and come back later. So we listen actively, face the patient, maintain non-authoritative posture, lean towards the patient, establish eye contact, and listen intently. Provide specific feedback about a behavior, about a procedure. So if the patient states to you, I don't want to have my blood drawn, we then have to provide specific feedback. So reiterating to them the essentials of why they need it drawn, and also possibly getting the nurse involved to let the patient know what they're looking for. Verbal communication, this is use of simple, straightforward vocabulary, use proper pronunciation and grammar, and avoid complex jargon or medical terminology. So for example, in phlebotomy, if a patient asks us, well, what are you drawing for? We don't want to be like, well, today we're drawing a CBC with diff and a complete metabolic panel. The patient's not going to understand what you're talking about. So sometimes it's more appropriate to say, well, we're doing a screening test. And if you want to know more information, contact your nurse or your physician. Communication across the generations. There's 4 major age groups. Traditionalists, born prior to the 1940s, are baby boomers, born mid-1940s to 1964. Generation X is 1965 to 1981, and Generation Y or millennials are born 1982 to 2006. Language other than English is estimated that about 460 languages are spoken in the U.S. Patients who do not speak English can understand basics from nonverbal cues. So for example, in drawing blood, sometimes just pointing to the patient's arm is enough for them to understand. Healthcare worker must know how to access translation services. This can be via phone. Sometimes other healthcare providers can also be a translator as well. In no time would a child be able to translate because of the complexity of some of our medical information we're providing. How to access a translator service. The healthcare worker who speaks other languages. There's audio recordings. There's also patient pamphlet information or written information in patient's language. And then there's also language services available by phone or internet, which is really helpful as well. Communication with other groups, so LGBTQ individuals who are lesbian, gay, bisexual, transgender, queer, or questioning their gender identity. There's also transgender individuals whose gender identity or expression does not align with their assigned birth sex. We need to be very culturally sensitive with this group. For laboratory testing, though, it is essential that we determine, and the physician normally will provide us the gender of the patient. If the gender is in question, we'll go back to the provider again to establish that. Just because it's based on if the patient hasn't gone through the full sex change, it is based on what the patient was born as, because male versus female, the test results do change. Immigrants and refugees, language differences, cultural differences, how they perceive touch, how they perceive, eye contact is very different. Fear of being in a new country, so helpful to their clinical condition for them to feel safe. But the language difference is huge. If they don't speak any English, this is where we have to be culturally sensitive. They might have a family member that's a representative for the family that we speak to them and then they speak to the patient. The other thing with cultural differences is that some cultures don't believe in certain procedures. So we got to be mindful of that and make sure that they're aware of the procedures we're performing. Sensory impairments, the healthcare workers knowledgeable about sensitive to patients who have impaired hearing or sight. All patients, regardless of impairments, must understand the healthcare procedures before beginning. So when working with those that are blind, these patients can still hear you. So you can explain the procedure. We're going to face the patient directly and speak to them. For patients that are deaf, we could write it out. Some have a computer-like system to where they could type out, questions, and we can type back as well. If the patient doesn't hear, try speak slightly louder, not shouting and slower, and repeat the statements if needed. Because a patient who is deaf can read lips, which really is helpful. Select the best option for communication, so written instructions, audible aids, tablet computers, smartphones. Be aware of the patient too. See if they have any type of hearing devices in. If needed, seek assistance from a sign language interpreter. Please be aware that if you have some sign language education, that's great, but we need someone that is fluent. Vision and sight impairment. So low vision, they can see degrees of light in some images caused often by macular degeneration and or diabetes. So sometimes they have sensitivity to light, so be mindful of that. All people who need alternate techniques to do the same tasks that a sighted person can do normally, so it could be communicated in Braille. Please be aware that these patients don't need to be guided. They set up their environment where they can walk around and do things for themselves. So really keeping good communication. Again, they could also use a long white cane or guide dogs. Please be aware for guide dogs, these are dogs for services, so they're not dogs that you can come up and pet and play with. So keep that in mind if you see this particular type of dog, and it will say service dog on the body. Patients who have visual impairments, when addressing a patient who is blind, speak directly to the patient. Do not raise your voice or speak to the companion if there is one. And the patient cannot see you, so introduce yourself as you shake their hand or introduce yourself so they're aware that you're present. Patients who are blind are entitled by law to use long white canes or guide dogs. Move furniture or medication out of the way prior to the venipuncture procedure, but let the patient know you're moving it. Let the patient know who is in the room if there are others present. Describe all procedures thoroughly and offer to answer any questions. Do not ask questions about their condition because you're curious. Do not make small talk about the patient's other senses, and most people who are blind do not want to be fussed over. Let me help you. Let me guide you. These patients can do a lot of things independently with no problems. So when communicating, we need to be aware of pace, so the rate of speed and urgency, because the faster we talk, the patient might perceive it as, oh my gosh, this is really, really important. Tone, high soprano to low baritone, and volume ranges from loud shouts to soft whispers. If the patient turns towards you, they may hear on that side better. So being aware of your volume. The patient will tell you if you're being too loud. But keep in mind, since it's early in the morning, we want to be polite and not come in shouting. Urgent situations, usually high-pitched, rapidly paced voice, sarcasm done by changing the tone of voice. Practice using a calm, soothing, moderating paced voice. Table 2.2 in your textbook is a great reference source. So nonverbal communication. This is positive body language. It aids in communication, makes patient interaction more pleasant, face-to-face positioning, relaxed hands, arms, and shoulders. The patient's going to notice your body language. They might see you every day for weeks on end getting their blood drawn. They're going to be aware of this. It does help in the communication process. There's also nonverbal communication, another positive body language. So erect posture, eye contact, smiling, in zone of comfort. In zone of comfort is how close we have to get to the patient. This is found in table 2.3 in your textbook. So body contact would be shaking hands. Sounds could be laughing. Appearance, are you clean, neat in appearance? Hand movements, are you someone that likes to talk with their hands? More of an emotional person. Eye movements. So if I'm looking up at the clock, it's showing that I'm disinterested, perhaps. So zone of comfort, intimate space, close relationships with whispering, embracing, personal space interactions among friends and many patient encounters, social space interactions of everyday life, and then public space. As phlebotomists, we're in a patient's intimate space. We are very, very close to them. We have to get close enough to the arm to be able to assess the site, clean it, and then draw it. So this is not a time we will be very close quarters, and be mindful that in this environment we don't want to wear any perfumes or colognes because it could irritate the patient as well. Cultural, so there's values, acceptable practices of groups, beliefs, doctrine, faith, and spiritual orientation, traditions and practices, customs, holidays, food. Consider your own culture when you're taking care of a patient. There might be a family representative that you speak to, or there might be certain foods they can't have, and they might have certain beliefs, so they might pray at certain points throughout the day, which is acceptable, and we need to be culturally aware of these differences and be accommodating. Negative body language, so wandering eyes, yawning, stretching, nervous behavior such as tapping a pen, breathing patterns, going crossed arms, wrinkled forehead, frequent glances at a clock, and chewing gum. As shown in these two images, we have ignoring. The technician's back is facing the patient. Aggressive, the patient standing above, or the technician standing above the patient can barely see them because of the fact that, the sun's in her eyes. This is especially true for when handling children. We want to bring them down to their level. So we'll make eye contact and we'll squat down to directly face our patient. So types of listeners, there's detached, passive, involved, and active. Detached avoids making eye contact. Passive may or may not make eye contact. Involved provides direct eye contact, and active has an alert posture using direct eye contact. Just kind of being aware of the different characteristics of each. So then we're going to go into our written communication. This could be online and handwritten schedules, quality control records, laboratory reports, medical and interventory records, and also legible permanent ink. So family visitors and significant others, they can make patients more secure. If they make unreasonable requests, we're going to inform a supervisor. Several visitors are in the patient's room. They may be asked to step out while the venipuncture is performed. Be sensitive to the patient's privacy and confidentiality in the presence of visitors. Do not reveal test results unless appropriate to do so and you have authorization to do so. Physicians, priests, or chaplains have the right to visit privately with the patient, so they'll let you know if you can be present there or not. The procedure is timed or stat, which means immediately. We're going to apologize for the interruption and explain the nature of the request and ask permission to collect the specimen. Families or visitors should not be permitted in the clinical laboratory where testing is performed. When encountering a patient for the first time, we're going to introduce yourself. You're going to state who you are and inform the patient that a blood specimen is being collected for a test ordered by the physician. Be calm, compassionate, and highly professional. Caution the patient the procedure may hurt a little but will be over soon. Avoid distractions by excessive talk and thank the patient for his or her cooperation. It is essential we get consent to perform the procedure as well. Confirm patient identification by three-way match. We're going to check the test requisition and labels, check the patient's hospital armband, ask for patient's verbal identification. If the patient does not have an armband, a positive confirmation must be made by a unit nurse, and the patient will need to be banded. Process well documented by the healthcare worker. When we communicate in an ambulatory setting, this would be an example would be like an outpatient setting. Mobile vans, off-site locations, homebound patients. Identity may include demographical data such as patient's ID number, date of birth, address, and phone number. We're going to confirm the information by the patient prior to the blood collection. There's the computerization in the clinical laboratory. So we have manual systems requiring requiring human intervention. So this would be like scanners, printers, semi-automated, little human intervention is required when we load our samples into the testing bays. They go through a machine, so very little human contact. And then we also have fully automated, little or no human interventions required. Know what systems are used in your healthcare facility. Table 2.4 in your textbook provides more detailed resources for this. Patient requisition and labels patient ID information. We need their full name, first and last, unique number, and location. The unique number could be their medical record number, gender, date of birth, physician ordering the test, and the test requested. Time and date of specimen collection, which will be written down by the phlebotomist after the procedure is done. Source of the specimen when appropriate. Pertinent clinical information when appropriate. Special comments, sampling site, race, ethnicity, and billing information if applicable. There's different barcodes. There's light and dark bands that relate to specific alphanumeric symbols. There's also QR codes and two-dimensional barcodes as well. There's also RFID and stat verbal requests via telephone in case of emergency or standardized form in laboratory prior to specimen collection. Labels containing following information, patient identification for each tube required, specific tests requested, and the types of specimen collection tubes required. Again, that unique identification number will be present. Smaller transfer labels for aliquot tubes, collection tubes, and cuvettes, and blood drawing lists by floor or unit, letting us know what room the patient might be in as well. Data to be considered. We're going to discuss data that should be considered for reporting laboratory test results. Some of the data that we need to be aware of would be like documentation of the patient's gender, documentation of the patient's age, because all that data will go back to our laboratory report results, because some results are reported by age, gender. It can also be specific to the ethnicity of the patient as well. Verbal reports documentation should include the patient's name and hospital number, name of the person receiving the report, date and time and information given, and name of the person issuing the report. Verbal reports provide us this documentation that we write down in case of critical test results as well. That way we have documentation that it was reported out. Electronic reports. So electronic devices provide a rapid report system, more reliable than verbal reports, and the results can be immediately available in each unit. And access for authorized personnel in each patient unit. Physicians can get access at a different hospital, which is really convenient. IDC codes based on body system and medical conditions or symptoms. It's also called ICD. ICD-10 is the newest version. They're codes that are specific to the test, surgeries, evaluation, and medical procedures. So each time you go into a physician's office, they're going to put a unique billing code in place based on what you had done. Medical records, documents, procedures, actions, and observations for each patient, legal record of the patient's visits, progress, and everything done to the patient. They're accessible in the court of law. EMR eliminates or reduces paper. It consolidates data to be accessed from multiple sites, and timely import of information from many other sites, which is really, really key as long as the internet's working. Okay, medical and health records, monitoring quality care, coordination of care, accrediting and licensing and legal protection, and research in teaching institutions. To monitor care is really essential in coordinating care, because if physicians can work across facilities, this allows for decrease in duplicate testing. It results in patients' recovery time being shorter and getting home sooner. So those are all things that are really essential. Important tips for documenting clinical information. We want to be accurate, objective, short, and legible. Errors should not be erased, only corrected. So we will actually cross the error out and put our initials next to it and then provide the corrected information. Electronic errors are corrected by authorized individuals only, and they include all relevant information in a timely manner. So it's more up to date. Confidentiality and privacy. So clinical information must be kept confidential and private. The healthcare workers must be careful not to disclose patient information in casual fashion. And discussion that does not directly relate to the healthcare workers' role in caring for the patients should always be avoided. We're going to cover communication as well as patient identification, patient interaction, and competency checklists 6 and 7 in class. What introduction and interview do we need to provide our patient? And then what should be on the patient label will be covered as well. Underneath the laboratory PowerPoint, which discuss patient interaction and patient identification. It's always essential when we communicate to be clear, concise, as we talked about, and also being aware that our verbal and nonverbal has an impact on our patient's recovery. The other thing too that we didn't talk about from this chapter is electronic messaging. So this would be email, it could be video, it could be text messaging. Being aware that sometimes when we do email communication, we want it to go to the appropriate sender and receiver. Sometimes too, if we write in all capitals, that could be mistaken for shouting. So just being aware of all types of communication we run into, both in and out of the medical setting. So the other key piece to chapter 2 is, again, making sure to read the chapter, complete the questions at the end of the chapter. All these will help assist you in preparing for the lecture test later this week. That concludes chapter 2 lecture presentation.